All right, so welcome everyone to session two of our learning collaborative about Lyme disease and Rocky Mountain spotted fever. So today we're going to talk about Lyme disease diagnosis and treatment. We're not going to get into the Lyme disease associated chronic illness. This is going to be more focused on issues that come up in the first few months after infection. So we'll review the signs and symptoms of Lyme disease today. We'll go over how it's diagnosed, how it's treated, and some of the potential challenges with those methods. And we'll talk about a couple of scenarios for farm workers. We use farm workers, that's our population that we focus on, but many of the issues confronted by farm workers when it comes to healthcare access in general are faced by many different immigrant and refugee populations. So we can talk about that depending on what types of patients you serve. You're welcome to put that in the chat as well. If you have patients who might be moving around for different reasons, if they speak languages other than English, and I can kind of adapt some of the examples as we go. All right, so this photo here is a black-legged tick. Have any of you had this bite you before? Maybe some of you on the East Coast. Um, all right. So just in case you missed last week, Lyme disease is a bacterial infection spread to people through the bite of black-legged ticks. And the most common symptoms are flu-like symptoms, which include fever, headache, fatigue, and then, of course, some people get that characteristic bullseye skin rash, which we'll refer to throughout the presentation as an EM rash. So if it's untreated, the infection can spread. It starts out localized and then it can spread to the joints, to the heart, to the nervous system. Um, and usually the EM rash is diagnosed just based on the appearance of the rash, along with the possibility of the patient being exposed to infected ticks. So you're all familiar in the chat, it sounds like, with the fact that you're in high incidence states, which are mostly concentrated in the Northeast. There are some states that have some local transmission. They're not considered a high incidence state, but you will see some cases pop up along the West Coast and in places like Illinois. So again, these are the signs and symptoms we see within about a month of someone being bitten by the tick. About 70 to 80% of people will have the EM rash, and it can look many different ways. I'm curious if you all have seen some non-typical EM rashes. The average onset of a rash is 7 days after the person is bitten by an infected tick. It's not itchy or painful, and let me move forward to show you. So that's the typical bullseye style rash. And then these are images of the rash that don't have that characteristic look. So it can be quite faint. The center can become crusted. It can have different shapes, like you see down here in the bottom right, that it has a ring, but not the bullseye center. Or the person can have multiple rashes. All right. Neurologic Lyme disease, this comes later. It can happen several weeks or months after the initial infection, and there's a couple of different symptoms depending on um, which parts of the nervous system are involved. So if there's cranial nerve involvement, that's when you can see the facial palsy. If there's peripheral nerve involvement, that would show up as pain, numbness, or weakness in the extremities, but that is very rare. There can also be central nervous system involvement. Again, it's quite rare, and that would be called Lyme meningitis. Someone could have a stiff neck, a headache, be sensitive to light, have those typical meningitis symptoms. If someone doesn't receive the antibiotic treatment in an earlier stage, they can have permanent damage to their nervous system. Lyme carditis can also show up weeks or months after the initial infection. According to the information that the CDC has, this occurs in about 1% of Lyme disease cases. So, not clearly not every case is reported to the CDC, but it is fairly rare based on what we do know. Um, if the person has cardiac symptoms present and Lyme disease is suspected for that person, then it's important to get an EKG. Lyme carditis does most commonly show up as an AV node block, and their cardiac symptoms could be things like chest pain, shortness of breath, or palpitations. And then, of course, this has the potential to be fatal. There's some research that indicates that it's more common in young adult males, Lyme carditis, so there's a 3-to-1 male to female ratio. It's not really known why there would be heart involvement in a Lyme disease case. The hypothesis is that there would be autoimmune inflammation because of an infection in the heart tissue. Rapid treatment is really important in these cases. It's not necessary to wait for test results to come back. It's really just recommended to treat if they're having those symptoms and they're suspected Lyme disease. Lastly, of the ones we're talking about today is Lyme arthritis. So this one tends to come later than the others, about 3 months or more after the initial infection, and it can show up as, joint pain and swelling. Um, I'll share a story. A couple years ago, we were collaborating with the CDC to do a cross-sectional survey with outdoor workers in New Jersey about Lyme disease and tick exposure in the workplace and at home and things like that. And we were visiting a nursery in New Jersey and talking to some of the workers there. And at that nursery, most of the workers were H-2A visa workers. So they were coming to the US for about 9 months at a time, and they would come and work in New Jersey and then go back to Mexico. Well, the guy in charge, kind of the lead, uh, the crew leader basically at the nursery, talked to me for a long time when I told him we were doing a survey about Lyme disease because he had been coming to the US on an H-2A visa for it was about 8 or 9 years when I spoke to him. And he had slowly gotten sicker and sicker after one of his visits to the US. He said he had some mild illness, like he felt like he had the flu, but then recovered quickly after that and ended up getting pretty sick, especially with arthritis symptoms. He said his joints hurt all the time and was having a lot of challenges. Went to the doctor in Mexico several times, and didn't get a diagnosis. And it wasn't until I think it was about 3 or 4 years after his infection that he was describing his pain to an outreach worker here in the US, and they knew about Lyme disease because they lived here all the time and recommended that he go in and get tested. And that's when they finally figured it out. So it had, especially for workers, the Lyme arthritis, he just described how much of an impact it had on his ability to work and to keep up with the demands of work. So diagnosing it when it's in the early localized phase, it can be diagnosed based on the signs and symptoms and the person's exposure to black-legged ticks. I'm curious for folks who are providers, what are some of the questions you would use to get at that exposure? I'm curious about that because especially for people who are outside all the time, um, and they may not see ticks on their body or they may not notice them for a while, if you have any tips on helping people recall their tick exposure. So it is recommended to test people only if they've spent time in areas where Lyme disease does occur to avoid false positives. If it's in a later stage, they're past like the fever headache phase, then there's a two-step serological testing process. The first step is an enzyme immunoassay, and then if that's positive, or if the results are indeterminate, then you would go on to the second round of testing. Of course, there can be false negatives with serologic testing if it's taken too soon because the infection hasn't seroconverted yet. And false positives can happen if the patient has some other conditions like syphilis, like rheumatoid arthritis, or the Epstein-Barr virus. I'm going to jump ahead. So, in terms of trends and diagnoses in the United States, we've had an overall kind of general trend in increasing numbers of cases. You can see there is a big jump in 2022, and I'm sure that quite a few of you are familiar with why that was due to a change in the definition of a Lyme disease case. So before 2022, to be defined as a Lyme disease case, it required a clinical exam and lab testing. Well, that put a really high burden on health departments in those states where there's a high incidence of Lyme disease. So that was changed. So now, if you're in a high incidence state, you can use lab testing alone. You don't have to have the clinical exam data to define a case as Lyme disease. If it's in a low incidence state, you would still need both lab testing and clinical exam data. But this change resulted in a pretty substantial increase in the number of cases that were reported on an annual basis. All right, we'll talk about treatment. 4 different treatment regimens based on what's happening with the patient. And all of these recommendations are based on the Infectious Diseases Society of America, their treatment guidelines for Lyme disease. So, with an EM rash in that early phase of Lyme disease, a 10 to 14-day course of oral antibiotics is recommended. If it's neurological and if it has parenchymal involvement of the brain or spinal cord, then IV antibiotics are recommended for 14 to 21 days. If it's neurological without parenchymal involvement of the brain or spinal cord, then you could do either the same IV treatment or oral doxycycline is also an option, and that would be for 14 to 21 days. We noted before that with neurologic Lyme disease, sometimes people will get facial palsy. Obviously, that's often treated with corticosteroids. If Lyme disease is suspected and there's facial palsy, then it's not recommended to use corticosteroids on top of the antibiotics. Of course, if Lyme disease doesn't seem to be involved, then corticosteroids would be recommended. For Lyme carditis, there's a differentiation in treatment. So if someone is not having very severe symptoms, if it's an outpatient treatment, then the recommendation is to do oral antibiotics for 14 to 21 days. If the patient is hospitalized, it changes to IV. So people will be hospitalized for arrhythmias or clinical signs of myopericarditis. Continuous ECG monitoring is recommended. Of course, they might need to do a pacemaker if bradycardia isn't being managed medically. But the treatment recommendation for those patients in the hospital would be IV antibiotics until they start to improve, and then switch to oral antibiotics after that. Lyme arthritis has the longest treatment regimen, and that is oral antibiotics for 28 days. Um, and that's for the first round. So there's another recommendation that if the person does that, they take the antibiotics for 28 days and they don't have a response to that, or the response is very minimal, then you can consider a second longer course of either IV or oral antibiotics, and that would be for another 2 to 4 weeks after that original 4 weeks. It's not, if they are having um, some response to the antibiotics, more than minimal response to the antibiotics, then there's not necessarily a strong recommendation to do another course of them. So this kind of summarizes the different treatment regimens based on um, based on what's happening with the patient. It's a little bit confusing, but you can see this kind of lays it out a little more simply. All right, so let's chat for a little bit. And you guys can use the chat. You don't have to come off mute unless you want to. But let's think about a patient, a farm worker patient, or an immigrant who has the EM rash. They need to take a 14-day course of antibiotics, and they're going to be leaving to return to Mexico in the next week. So they have to leave before they can finish their course of antibiotics. What are some issues that might come up for this worker in terms of, potentially losing their medication, um, lacking a healthcare provider either en route back to Mexico or once they're in Mexico? And then if they do have a healthcare provider in Mexico, they may not be familiar with Lyme disease. So, what are some pieces of advice or information or resources that you would give to that worker in that circumstance? Or what are some other issues that might come up for them? Yeah, so Tiffany, thank you for sharing. She said give them appropriate instructions and informational material for them and their potential provider. Is that type of information available in Spanish to give to patients in your experience? Yeah, and making sure they're prescribed a medication available at home. That's a good idea. In their country of origin, that if they lost it, they could get the same medication replaced. I'm wondering if Dr. Marks or anyone else on here is familiar. If someone started one type of oral antibiotics, could they do one of the other ones if they lost their medication midway? Or does it need to be the same antibiotic the whole time?
You can certainly switch antibiotics if necessary. The antibiotics that are recommended for Lyme disease are fairly accessible I'm thinking about Central American countries, often even without prescriptions. Amoxicillin in particular, I've seen on the shelf in Honduras and Mexico. But it's certainly possible to switch. The only caveat is that for doxycycline, for example, for an EM rash, you can just take a 10-day course, and amoxicillin is recommended for a full 14 days. So if you were started on doxy and you switched to amoxicillin, you would have to make sure that they know they would have to take it for a few more days.
Thank you. And Tiffany said that I think you're referring to the um, informational material, if that would be available in Spanish. Do you, Juan and Finger Lakes, do you guys have that type of information on Lyme disease available in Spanish?
Oh, hello. Yes, we would have that through public health, but I mean, sometimes they'll send us just links from the CDC. I mean, that's typically the educational material we have, and then whatever our EMR would print out based on treatment, and that could be printed out in Spanish too.
Yeah. Okay. That's cool. We worked on this. I have some, I can advance real quick. There are some resources that we have that we worked with CDC on a couple of years ago as a result of that study, and it's mostly about removing ticks and post-exposure prophylaxis, but we didn't create anything about the treatment and what that would look like um, for somebody who has Lyme disease. So yeah, I'm wondering if there are multilingual resources on that. Um, yeah, thank you for
And
sharing
we
that,
also
Beth.
we check with the patient their knowledge on antibiotics too, if they've heard of them too. So it's from back home. So we also try to see, have you heard of like doxycycline or
That's
just
great. Yeah, that's really good. Um, that's cool. Have people, so when we talk to people in New Jersey, they really overall were not aware, outdoor workers were not aware of the fact that ticks could transmit Lyme disease specifically, or that sometimes they had an association that they could transmit some kind of disease, but weren't really sure what. And I'm wondering if other people have had that same experience in their communities.
this year. Well, in our communities, they do come off like they do come off surprised a lot of the times when we start the conversation. We ask, part of our screening is, um, have you been exposed or have you heard of Lyme disease in your occupation or while working? Um, And most say no. Some say, they have had a tick by back home in their country, Mexico, Guatemala. So we start talking about Lyme disease and the risk of getting that, right? Getting that disease. Um, but with Lyme disease, only when it happens to, well, I don't want to say only, but when it happens to someone close to them, that's when it hits home, right? So that's when they
Mhm.
start to be more interested in listening on that topic. So like, oh, my sister got Lyme disease and she ended up dying from it. Then, you know, it usually like spreads out through the whole camp where we're at. So that's when they start more, taking in that information that you're providing on that education.
Well, yeah, that's too bad if it has, if it takes that to get people's attention.
Yeah, it's because usually what we see is they're here to, their mindset is they're here to, do their work. Um, until something happens, that's when really, or something happens to one of their coworkers that's with them that came with them, or um, that's when they start taking in more of that education and asking more questions and being more proactive with their health,
Yeah.
especially
Yeah.
younger populations.
And there's only so many hours in the day for
Hmm.
people, there's so many aspects of life to attend to that, yeah. But that's good you're out doing that education. Emily, I'm curious since you're in Vermont. I was just in Vermont about a month ago talking to farm workers there, and I'm curious to hear who's been at risk in Vermont or what your experience has been there with Lyme disease in that state. Maybe we lost her. How about Maryland? There's quite a few people from Maryland.
Hi, this is Karen from Connecticut. I could chime in until the Maryland folks can join. In 2023, the Yale Emerging Infections Program conducted a focus group of farm workers, really to sort of understand their knowledge of tick-borne disease, health education, prevention materials, and they shared with them new educational materials as well as what you see on the CDC website. And the majority agree that they have seen tick-borne diseases, and they provided some suggestions on how to revise or update some of these tick-borne disease educational materials on the CDC website to make it more clearer and to reach the agricultural community, and it would be helpful for them. I think it's on CDC's website now, which is the ticks can cause disease, and it's in English and Spanish, and it's a male and female agricultural worker, and shows the location where the ticks can be found. Um, and so they provided some comments on some of these educational materials that will be helpful for this particular community.
That's awesome. Was that done with the Connecticut River Valley Farm Worker Health Program?
Yes, it was. Yep.
They do such great work. That's wonderful to hear. Yeah, we did a similar project in Virginia, I think, looking at different materials, and we could share the results of that in this chat. I don't know, Karen, if Yale published the results of their work, that would be interesting to see.
I I'm not sure if they publish the findings. They typically do, since it's a research organization with CDC funding. However, this was um, funding was limited or reduced for their first year of their 5-year grant cycle. So I think they were able to accomplish the work, but I'm not sure if they were able to publish on it. I could definitely follow up and see if that is available. I'd be happy to share with folks.
Thank you. Yeah, I think that would be really interesting to see if it is available. Thank you for sharing that. And Carrie, thanks for chiming in here too in the chat. So yes, that does seem to be common that if the word has gotten out about Lyme disease, that people do think that all types of ticks carry Lyme disease, and that you have to have the bullseye rash to be diagnosed. Yeah, those classic symptoms. It's been the same thing educating farm workers about bird flu and also clinicians to some extent that people think you have to have conjunctivitis to be infected with bird flu when that's not the case. Um, yeah, so we didn't include the Lone Star ticks. I think there have been a few cases of that, if I'm remembering correctly. Um, one of the epidemiologists might have more knowledge about that, but I think there has been a little bit, but maybe not a broad concern at this time.
This is Pennsylvania. If I could chime in just a little bit here. So what we during COVID, we had a number of COVID outbreaks at farms. So we made a lot of connections during COVID, and so we kind of leveraged those with our vector-borne team, and we asked the growers themselves to establish vector prevention stations on their farms, and if we would provide the materials, would they do that for us? And so they did. A number of them did, and so we sent them permethrin, insect repellents, and things like that. And we asked them what languages they needed, and most of them said Spanish, a couple said Haitian Creole. But also some of them said low literacy, which we found to be the most challenging because, of course, we work with translators who can translate almost any language. But the low literacy was something that was not something we were necessarily prepared for, and we sort of had to start from scratch because we weren't really able to find low literacy tick and mosquito prevention materials online. So our public health educator came up with some low literacy materials, and I think they're pretty good. But I mean, if anyone has anything that's kind of a gold standard or anything like that, we'd be very interested in that. But yeah, so that's what we found to be the most challenging.
That's a really neat partnership that you guys developed with employers. That's really cool. Or with producers. Yeah, I'm sure we'd love to see your materials. Alexis and Lisbeth, my colleagues, are kind of our in-house health education experts. And yeah, low literacy is very hard. It's very, very hard. We've often found that using metaphors is often the best way to go. Uh-oh, Alexis, did I mess up the slides?
No, I don't think so. These are the resources.
Okay, good. But yeah, I'd love to see the materials you guys just developed in Pennsylvania. And then I was going to check in. Emily said she shared some information about Vermont, that they do a social media campaign every year around now about tick prevention and avoiding tick bites and have free educational materials to the public. That's really cool. Okay, Dr. Marks corrected me about Lone Star ticks. They do not carry the bacteria that causes Lyme disease. So, good to know. All right. Yeah, people can feel free to share their materials so other people have them. I know Lisbeth shared a few in the chat, but feel free to share any others. All right, let me go back to this last slide here. Yeah, so this is a similar question really to the first one, but this time if the patient is returning to Mexico and they have, to do a 4-week treatment, would there be any additional information that that patient might need compared to someone taking just a 10-day course of antibiotics if they're going to another state or to another country? Okay, awesome. Thank you, Leah, for sharing that information about ticks. Did you guys aim for a certain grade level in your materials?
Um, we did, and I'm blanking as to what grade level it was. I want to say like fourth grade or something, but I don't recall exactly. And again, it's our public health educator has moved on to another position, but she developed all of them. So
Awesome. That's great. Yeah, we usually try 3rd or 4th grade and it's very challenging. It can be really hard. Okay. And Tiffany thinks, so this is in response to the second scenario, emphasizing the potential consequences for not finishing a course of antibiotics and making sure they have a place to store their meds during travel and at work, which yeah, that can be a big deal. All right, cool. Any other thoughts on this scenario? Any other items? Um, okay. I'm going to scroll forward again. All right, so we shared this. The link to those are in the chat already. Um, that's my email. If folks have questions, you can drop them in the chat or come off of mute. I am going to post the evaluation. But yeah, feel free to share any lingering questions you have.